manage acute complications of diabetes. And when I talk about acute complications, I'm talking about the hyperglycemic crises. So there are two types. All right, so with hyperglycemia, the major problem is that the metabolism pathway is altered. With too much glucose in the bloodstream, the usual metabolic pathway for glucose is altered. Secondly, there is no insulin to take excess glucose into the cells. Then they stay in there, and the cells are now starved of glucose that they need for a number of metabolic processes. So the body is starved, the cells are starved, they have to make glucose from non-glucose. First they're going to go to glycogen and use that up. Then once they're done with that, they're going to start making glucose of proteins, which is a neoglucogenetic kind of pathway. Completely different. You're going to have a whole bunch of different ketone bodies being produced as byproducts. You're going to have acidotic state, and all of these contribute to what the problem is. And we will go through each of the different things that happens. But for you to know where is, so you need to know what is happening, and then what is the consequence of what's happening, and then to deal with it. So other glycemic states can be, of course, diabetes can produce these, non-ketotic osmolar coma, which is also because of lack of glucose, impaired glucose tolerance, stress, hyperglycemia. So basically all of these things can cause hyperglycemia. Other things that can cause high ketone bodies is alcoholic ketosis, sedation, or because of hyperglycemia, you can also get ketosis going on. So metabolic states can be caused by lactic acidosis, hypochloremic acidosis, salicylism, people who OD with aspirin. Uremic acidosis in renal failure, drug-induced, of course, acidosis. So let me see if I can blur this a little bit up. Okay, I think this is the best I can get. All right, so the pathogenesis of DKA, basically the bottom line is you don't have insulin. All right, so you don't have insulin, then if you do not have insulin, then the counter-regulatory hormones to insulin are glucagon, catecholamines, cortisol, growth hormone. This is why when you have hypoglycemia and you have people with hyperadrenergic system or adrenergic drive, you have increased palpitation, increased respiration, you get glucose being brought into the bloodstream through non-gluconeogenesis pathway. So, in stress situation, cortisol is that mediator for increasing glucose. All right, so you could have a state of complete insulin deficiency. You could have altered state, absolute or relative, Either way is going to take you in the same pathway with these hormones predominating. And so what you get increase in lipolysis, you're going to get increase in conversion of fat, conversion of proteins through fat into making new glucose. And all of that will release byproduct that are fatty acids, ketone bodies. You have hyperglycemia in the blood. You would then what will set up in the blood is increase in solutes. Whenever you have increase in solutes, what happens to the bloodstream? When you have solute content going up because of glucose or any other thing that is a solute, what happens in the bloodstream? Increases what? Yes, but also increases the content of solute. So it increases viscosity. How do you measure that? But the other word that I'm looking for is what? So viscosity and then what else? What is the other word? Osmolarity of the blood. Okay. So when viscosity goes up, what happens?
Pressure. Blood clotting.
So basically, when it's viscous, it means that things are not flowing the way they're supposed to, right? So the things are able to, there's stasis, if you will, and so you could get clotting, like she said. What else will you get?
Pressure.
What did you say?
I was saying pressure, blood pressure.
How does it go? Which direction is it going to go?
Oh, increase. So maybe
Okay, increase because of. Alright, this is what I'm trying to get you to think. Okay. I want you to start with the problem is too much glucose, right? So I want you to start with glucose and all the different things that glucose can do. Once you get this, there's no way you're gonna not know what's going on when you see a patient. This is what I'm trying to get you to understand. So let's see what usually the different things that will happen with increase in glucose in the blood. We talked about now the blood itself is becoming more viscous. We know we're talking about too much solute in there. What is going to happen to the serum concentration? And if you're looking at concentration of different products, in particular for glucose, what has now happened here? Hypoglycemia, and so high concentration of glucose in the blood, more than what it should be. So if you have across the membrane, no glucose on that side and high over here, you set up what? It's a gradient you set up, right? Mm-hmm. Too much glucose in here is going to drag water from inside out. Are you seeing this? I don't know, what is my blackboard in here that I can draw on? No. There's, this is why I'm in the airport, so I can use that board. It allows me to draw, so I'll give you to draw. Okay, so here's my whiteboard. Alright, great. So here is the blood, let's think of it as, okay, so this is blood vessels. Let's say in the vessels here. And here is extracellular area. Okay, so here where the cells are. Okay, so you have in here lots of glucose that's not supposed to be here. Usually when glucose comes from over here like this, the directional move is this way, but you need insulin, right? Insulin is needed for that move to happen. So you need insulin to help you out. So then you have just tiny amount of insulin in here. And you have tons of water in here. Because over here, your fluid level is so tiny now because you now have so much solute. So the direction of flow for water will be in this direction. All set up in the extracellular space or inside the tissues. What is going to happen?
Edema.
How can it be edema? Please think.
What is going inside?
Thank you, because the water is now the concentrational movement gradient. You remember your concentration gradient across semi-permeable membrane, which is what this is? It's a semi-permeable membrane.
But it's going inside.
Where is the swelling happening? So be specific when you tell me about swelling. Where is the swelling? Is it inside the vessels, in the intra-arterial space, intravenous space? Where is the swelling happening at? Because I'm telling you, inside the venous and arterial spaces, you have so much glucose in there because it's not going through the plasma membrane into the tissues and cells where it's being used. So if you concentrate out here inside the blood vessels, which is what that left-hand side is, the blood vessels over here, what will happen is water has to go in this direction to try, because there's always going to be equilibrium across that membrane. That's what the body does. It wants equilibrium. So water will start moving in this direction. Glucose is still sitting here. We don't have no insulin to help us take it in. So there's going to be dilutional here, yeah, eventually. One of the things that you mentioned, there will be intravascular increase in fluid and volume of the intravascular space. That can potentially increase blood pressure to some extent. But the other thing that's going to happen is, over here, what will happen to your cells? They will shrink and collapse on themselves and die. So dehydration sets up because of that, and these are the key components of what's going on. When you see your patient, you need to know, if you don't understand this mechanism, you cannot explain what's going on. But you need to be able to explain what's going on and understand it to know what are we going to treat. So now, I'm telling you that people come in severely dehydrated, though they have fluid, because glucose is, what is glucose? As a drug, what is glucose? As a drug, what is glucose? Okay, what are the other,
Carbohydrates.
what are other sugars that you know? All right, so what, these are keys and they're just looking at me like.
You said drugs.
Yeah, what other drugs does glucose remind you of? Because you need to think in terms of mechanism. Can you say that out? All right, so this is the drug that I'm looking for. The drug that I'm looking for.
That's the brand name. Glycogen.
Okay, because it does make up the component of glycogen, but it's not, so. Okay. All right, let's go back. This is fundamental, people. If you do not understand this, then we want to say just go home. Because you cannot understand why your patient will have subsequently everything I say after this. If you don't get this, forget it right now. So you need to really get it. I'm going to spend time to make sure you get it. You need to understand what is going on with glucose itself. Why do we see what we are seeing? What's the reason? That it's a biochemical pathophysiological mechanism that's going on that we need to understand. So, glucose acts as what? Just when I'm telling you that glucose is sitting over here in the left side, inside the vessels, and water is running to it, what other drugs do this? What drugs drag water to themselves and release them in the kidneys for us to flush them out? Thank you. Thank you. So think. Connection. No. This is where, that's why you're in this class. So that you need to connect the dots. You need to be able to make sure, because in the board, and when you see patients, you need to be able to connect that. And pathophysiology mechanism needs to make, sense to you. When you see patients with diseases that you need to know the pathophys.
You said drugs.
Yes.
That's a class of drugs, right?
That's right, and that's what I asked. I said, there's a function when something that draws blood to itself, what drugs do that? Okay, the classes of drugs that are just like glucose, what class of drugs are those that are also used for that as a diuretic? Thank you. So glucose glucose draws water to itself, just like what other agents that we know are diuretic that are used to draw water out in cases of edema. What are those drugs? Don't just tell me diuretics. I want the names. I said, what are the names of these drugs? What other class does this? That are basically sugars. Alcoholizers is not, it's not sugar. Yes, mannitol. I think you didn't say that. I didn't hear you. But sitting right here, I didn't hear it. No, I didn't hear it. You should have streamed it if you knew. And you're convinced. That's what I'm asking. So, this is what needs to happen. You need to make this connection, people. You need to make this connection. There's a connection between all of this stuff. So, here now. Gee, what's this?
Just turn the volume down on your laptop.
Are you trying to record?
Yeah, I'm recording
It's,
for
yeah.
people that are not listening them somewhere.
I don't think. Oh.
All right.
Just the volume.
Let me mute it.
All right. Okay, so I think I got it now. All right, so.
If you muted it, they're not going to be able to hear you.
Oh, really?
You should have a volume set like that. On the side. Is it you?
You got technology.
Then
All right, so let's just manage this. Can somebody else maybe like record on their cell phone or something? That way we can.
You can take off the volume.
I took it off, it's still doing this. Anyway, okay. So let's continue. Okay, great, thank you. Let's see if you can. Okay. So. Okay, thank you. So, all right. So now we've established that glucose is like a diuretic. It's a diuretic. It's still doing it. So what will he start doing? He's drawing water out. He's flushing it through the kidneys. Oh, sorry. All right. So this is a diuretic. Okay, let's see if it works. So we now have a diuretic that we have in the blood, and it's drawing water out, and it's flushing it, and then the people don't know that they have hypoglycemia. This is actually one of the reasons why they get into the crisis, is what's set up by all of this. But as you're flushing water out, what goes with water? What are those elements that go with water? That's right, your electrolytes will be flushed with it, just like as if you gave them diuretic. They will dislodge sodium, potassium, name it. Everything will just go into disarray. Now, what have you set up? You've set up a non-physiological kind of environment for the body that it doesn't understand. And therein lies all of the symptomatology that you're going to see and the consequences that happens to the patient in this kind of situation. So electrolyte imbalance is here. First of all, let's figure out what we do not have. We know we don't have insulin here. Number two, somebody is taking our water out of the body, so now here they become dehydrated. So they come in to you, and by the time you see them, by the time they start to complain, they're severely dehydrated. Their body water, you remember we talked about some water when we did it through an electrolyte the other week. And so this plays into that. So some of the dehydration, fluid imbalance, and deficiency, so you can actually calculate how much fluid are they deficit in and how much you need to replace. And we will go through that. then they have electrolyte imbalance. All right, and of course, there's an underlying reason why this whole thing started to start with. It could be disease. We can also talk about that in a few minutes. All right. Okay. All right. In hospitals, in terms of, or if you're assessing them, if you're assessing the patient, in terms of what do you need to do, these are some of the things that you need to pay attention to. And I'm trying to see if we can go up. All right, so we already mentioned they're going to come in electrolyte imbalance. They're going to have acid-base disorder. Insulin is not there anyways. We already know this how the entire thing started. They're going to have fluid problems. If their kidney is still functioning, they may be flushing around, or if it's not flushing as fast as it should, then they are also at the same time having edema where they shouldn't be. Okay, so it could be very complicated, the picture, but if you know what the problems are, then you know how you're going to treat and deal with it. Question?
Dr. Osemeni,
Can you come back?
We can't see them.
is it possible to send this one to us? Because we cannot see anymore. We cannot
Okay.
follow that.
Okay, so this one is just basically it's a spreadsheet for collecting information when your patient comes to the hospital. This is actually one from a hospital that I've made a picture of and put in here so you can see what it looks like. So here is the flow sheet.
Is it on the slide?
And it's not in the slide.
Because I don't see it in the slide.
Yeah, Linda just asked if you could send it to us.
Yeah.
All right, so what is here? I don't need to send you nothing because these are all cells, and what do you want to see? The cells? I'd rather you understand what's on there. So what are the information that is on here? This is just a flow sheet that you might use, or that you find them in hospitals. They use this in the units. Basically, the name, the date, and when they were admitted. Of course, your vital signs and such, you get that. Blood glucose, like all those, you get. But also, you want to establish what are the electrolytes. What are the immediately as they come in? What is that picture of the electrolyte imbalance? What does it look like? So what is sodium, what is potassium, what is chloride? You know, your chemistry, you just get those. Also, people immediately start to check ABG, which is your, to be able to see what is your acid-base status. So they want to see pH and things. You can only get it from when you send for blood gas. So they do a blood gas, okay? And blood gas, you're going to get your PCO2, PO2, oxygen saturation, and then of course your pH, chloride and things like that. Then insulin, okay, they're gonna evaluate, are they on insulin on therapy outpatient, or are they not? Are they on oral meds? How much? And then also, just by the mere fact that you've inspected the glucose level when they come, almost high, always high, how much insulin are you going to start in the therapy? All right? And then what are you going to initiate it with? The next thing is for you to think about the fluid. What kind of fluid level deficit do they have, and how much are we going to give them, and what fluid are we going to use? D5W, are we going to be doing normal saline, half normal with D5? When do you do that? And then, of course, you want to make sure you monitor the output for the urine. So what kind of urine are they putting out? Because in most cases, people that come in this disorder are type 1 diabetic and some type 2 diabetics that, they're long-standing diabetics, they probably have renal impairment, so that's the main reason why you're looking at the kidney function and outputs. All right, so basically that's what's on this spreadsheet, nothing else except those things. Now, okay, so here, I want to talk to you. So I'm leading to our patient, but I want to tell you about the 5 major functions of insulin. And if you do not have insulin, these 5 things are at play with the disorder that you're looking at. So we already established that insulin does drive glucose into the cells. It drives potassium. So as it's driving glucose in, potassium will be trying to escape with glucose back inside the cell. Remember, potassium is an intracellular iron, right, or cation. So insulin is at the forefront of the driver for both potassium and glucose into the cell. So those two things. So every time you give someone glucose with insulin, they will most likely start to display hypokalemia very shortly if you're not taking into account what's going on. So you need to really be monitoring and replacing some potassium because it's going to be driven inside the cell. Insulin as itself is an anabolic hormone. In other words, it helps you to build fat and muscle. It will inhibit lipolysis. It will inhibit you from taking anything out of the fat vapor. It will rather want to even deposit some more. So insulin is anabolic. Okay. It blocks both fat and protein breakdown because of that. So the impact of insulin deficiency, which is what we're talking about here, the hyperglycemia, osmotic diuresis, dehydration, ketosis production because you don't have glucose, your body's going to be trying to make glucose from other sources, i.e. protein, and at some point, triglycerides. So we already talked about this, the fact that insulin will facilitate movement of glucose inside the cell. So lack of insulin, of course, will sort of like lead to hyperglycemia, hyperkalemia at the beginning, and catabolic states, protein broken down to create glucose from non-glucose sources. And of course, that's your picture of your diabetic ketoacidosis, DKA. So, what are the 5 things that will cause diabetic ketoacidosis? Infection. Infection, the 5 I's, so write 5 I's down. I number 1, infection. I number 2, infection. So if they have myocardial infarction, stroke, bowel, bone, or anything like that, problems, they may get hyperglycemia. Pregnancy. And then people non-compliance, so indiscretion with diet or non-diet compliance. If you are diabetic, you're not doing your insulin as you should, lack of insulin, so also you don't have your, if you're on pump, maybe if the equipment fails or you're not just injecting what you need to inject at the time that you need to do it, then you could have problems. So these are 5 things that will trigger hyperglycemic states in diabetic patients. And also in the setting of infection, myocardial infarction, particularly the diabetic as well, it can happen. All right, so the one thing that I want you to pay attention to, the single most common cause of it, aside from infection, people are doing what they're supposed to do with their insulin doses, so non-compliance. Okay, so 5 diabetic emergencies that we need to look at, and which is what we're looking at: ketoacidosis, hyperglycemic state. I'm not going to talk too much about hypoglycemic state. So in this 1.5 hours, I want you to know primary action of insulin. We talked about some of that already. I'm trying to get you to understand the causes of diabetic emergencies, which is basically the glucose and the pathophysiology of it, and how do you recognize the signs and symptoms that goes with these. Okay, so I'm going to skip through that, and then you can only understand this by going through your case and understanding it via that patient. Okay, so here comes the patient, and they say something to this effect: I've been feeling very tired, and all of a sudden I feel like I'm always in the bathroom because I drink so much water. I felt like this before, and the doctor told me I was having a lung attack. So I guess I'm having another lung attack. I've also been feeling very nauseous, and my stomach hurts so bad. So let's deconstruct what they just told us. So they're telling you now, oh my God, I'm running to the bathroom every time. What would you immediately think of? Okay, but let's go to you as a pharmacist, and you're saying to yourself, yeah, polyuria, but what are the differential diagnosis, differential causes, what would cause them this stuff?
It depends on if, you gotta ask how much water. Because sometimes you're not even drinking that much water.
Well, no, the level of going to the bathroom, if you have normal renal function, your body should be able to control that. Yeah. Through your thirst mechanism, but of course, in this kind of setting, your thirst mechanism will go up because. So, what are you thinking about? I want you to think of the several different things that could be happening to the patient. When they come there and say, well, I'm running to the bathroom every time, what are you going to be thinking about?
Are they on diarrhea?
Are they on diarrhea? Thank you. Are they doing that? Are they, what could be diarrhea in them? So now you say to yourself, okay, so then you're going to be trying to think, okay, you talk to them and you evaluate and say, are you on diarrhea? No. Then you get history that's showing you that they are diabetic, right? So then you start to think what? It's caused by glucose that is diuretic in this case. Alright? And then they're also talking about this lung attack, and basically,
Is there an infection?
exactly. Is there an infection? Did they have infection? Because, and of course, your lay people, they do not understand, so you understand when they tell you this. And also they're talking about nausea and stomach hurts. Maybe it's a viral infection, or maybe, depending on age, it could be bacteria, maybe pneumonia or something. Okay, so we have JJ, 52-year-old Hispanic male, states that he has become very lethargic and fatigued over the past day. He states that he has been feeling nauseous with abdominal pain since yesterday morning. He states that he has in his normal state of health he was in his normal state of health until a week ago when he started to have increased sputum. See that lung attack? Sputum was having increased sputum that was purulent in nature, productive, and he was also having dyspnea. He was discharged from hospital 3 months ago from pseudomonal COPD exacerbation. See how everything is coming together in what they told you and what you're seeing from what you're getting in the history of present illness. Now it's making sense. So now you're delving in what do you have any allergies? Are you acetaminophen and penicillin in this case? What's your prior medical history? You're looking into the chart. If there are prior patients of yours in your hospital or clinic, you see hypertension, they have type 2 for 20 years, they have COPD, CAD, their history of MI with cabbage times 3. Multiple COPD exacerbations, social history, the occasional ethanol use, they smoked for 20 years. At this time is when you want to know, are they still smoking? Are we going to be doing smoking cessation, post-resolution of this crisis right now? So cabbage times 3 in 2014, basically that stands, right? Measurement of blood pressure shows 102/62, heart rate 110, respiration 24, everything, is not normal. Weight 184, height 62 inches, and temperature low grade fever at 99.1. So you're doing your due diligence as the clinical pharmacist, you're looking at the skin. They have poor skin turgor. You're looking at lung tachypneic, they're breathing 24 per minute. You try to check their neuro and their alert and oriented times 3. So when you say alert, oriented times 3, what are they oriented to? To what? To place, time, oriented times 3, what is it? Okay, to who they are. They need to know themselves that they are them, because if you're going like this, you don't even know it's you. So confusion can set up in here because of the fact that they are extremely dehydrated, and so the brain, cerebral fluid, don't like to be messed with. So if the level is going down, and they just go cuckoo. And also that the ketoacidosis can also make them go cuckoo over there because just the environment is not abnormal for the cells. So lab is drawn, sodium 138, potassium 4.8, chloride 98. Pay attention because potassium may be looking high, but really total body potassium is low because you remember I said if there's no glucose, potassium is not going from outside the cell inside. It is sitting out there and inside it's like low. So when you look at total body potassium in this setting, they're usually always low. Of course, sodium will be low, and here the dehydrated, we know it looks concentrated, but it's not. It looks like it's normal, but it's not. Okay, CO2 13, BUN 30, serum creatinine 1.5, glucose 425. So people check white blood cells to see the infection going on because, of course, some of the symptoms showed us that. White blood cell 14, is that normal? Hemoglobin of 14, creat 40.8, platelet to 80, oocytes 90%. Is that normal? A1C 9.5. Well, that tells you everything right there. Okay. LDL 225, triglycerides 195, HDL 42. You did what you needed to do. You pick up some urine from them. You check for ketones. It's plus ketones. Spilling glucose into the urine, huge amount plus. Okay, people have done chest X-ray because of the complication. Of the history of present illness and what they're complaining of. But chest X-ray didn't show anything. Perhaps they've been treated for a little while before they showed up. EKG, sinus, tachycardia. Well, there's been tachycardia because even though there's hyperglycemia inside of the cell, inside of the intravascular space, i.e. your arterial and venous vessels and capillaries, the cells don't see it. So, because the cells don't see it, the cells says to themselves, folks, we are in hypoglycemic state. So, what are those 5 counter-regulatory hormones that are going to go up? Cortisol is going to go up, growth hormone is going to go up, your adrenal catecholamines are going to go up, and these, particularly your catecholamines, is going to increase sympathetic tone, which is why they're going to be tachycardic and they'll be breathing, like that. Okay, so they did cultures times 2. Of course, it takes a while for us to see that. They did both the cultures on blood and sputum. All right, here is some more lab. Your ABG came back, pH 7.26. Millimeter of mercury, PCO 221, then BICAR 7.1, PO2 128. So they're looking at barometric pressure of these different gases in the blood. There are normal ranges for these, so you can tell if things are off. And of course, the ABG, the oxygen side is 97, which is good. The 90% over there was a little bit concerning, but you want it to be higher up. Okay, sodium here, which is ABG. Now I want to tell you the difference between the chemistry that you saw before. The chemistry was the venous blood. Always, ABGs are drawn from arterial blood. And of course, the oxygenation from those two blood is different. Remember, you always have arterial blood more oxygenated than your venous, because remember your venous is taking everything with all of the dirt in it back to be cleansed of too much CO2, all of your chemical byproducts. So this blood, the arterial, usually when they do ABGs, oxygen is always high there, but it's the most accurate to show if people are in acidosis and things. Alright, so sodium 132, potassium from ABG is 4. Now, the numbers could be a little bit different from venous blood, like I said, versus the arterial blood that they use for ABGs. So CO2 10, here, BUN 23, serum creatinine. So, first thing to note, if there's ABG done, use these numbers to calculate your anion gap, to do the osmolarity calculation and such. So, let's start by doing that. So folks, calculate what is the anion gap for this patient, because we know they're what? From the pH. What does this pH tell us? What is this pH?
7.26.
What is it?
Is acidic.
Why is it acidic?
I said this in person.
Why is it acidic? You're right.
Less than 6.9, it states that it's acidic, it's acidosis, according to our expert. So I'm kind of confused why 7.28.
Okay, 7.26, because what's the normal range?
7.35.
35 to what? It's a range. How is the range?
7.45. 35 to 45.
So, here is the range of normal pH. So if they come in here and measure all of us, we'll be somewhere here. Anything lower on this side here is aciduria. Okay. It goes down 7.32, it's acidotic already. Okay. It goes up over here, it's alkalotic. 7.46, 7.8, 4.9 is alkalotic. It needs to be somewhere here. So if it goes in between anywhere there, it's falling off in the wrong direction. So your patients who come, if they in the state that we're discussing, acidotic and in diabetic ketoacidosis, their pH will be in this range. Will be in this range. Yeah, 7.26 it's terrible because a lot of things are happening and you don't want it to keep going lower and lower and lower. They already started to have issues. There's already changes in biochemistry, in the physiology, processes in the body because he doesn't like to live over there. He doesn't live there. He lives over here. And then you drag it over to 7.26. Functions that are happening will not be happening the way they should be optimally. And so there's a problem, folks. The acidotic. Is this clear?
Yes, ma'am.
Alright, so a patient is acidotic, so I want you to tell me what is the anion gap, because you want to see what is the excess ions, positive ions, which is hydrogen ions, mostly because of the generation of ketones. What is actually titrating this whole thing is ketones. It's titrating your base and taking it down. So the more that you titrate, the more acidosis that's happening, the more that number will keep going from 7.2, 7.21, to 7.0 to then 6, then severe acidosis that at that point they may get into diabetic coma. What is the anion gap? How do you calculate anion gap?
Sodium plus potassium minus chlorine minus bicarbonate.
Yes. So basically your anion gap is looking at to see what the excess is in terms of hydrogen ions. So you're looking at all of your cations, minus all of your anions. Alright? Which ones are your cations? course, your potassium. But you know that potassium is intracellular, so I always say add it because when people are doing estimation, they usually try to not worry about it because you remember sodium is already 100 and something, and then potassium is just 4. So whether you add it or not, it doesn't make sense. It doesn't make any difference. But I want you to add it for this class because I want you to always make sure that you're looking at all of the iron, all of the cations that's going on. Of course, over here is chloride plus your bicarb. What we are not adding here that we should, on this side here are your proteins, okay? So proteins, because they have that, remember that side chain, OH, which is probably, I can't write on it. You have that acid side chain that is anionic. Remember? So your proteins, and a lot of proteins are in blood, big proteins. It's not often measured, so it's okay if you don't have the numbers, just do, but the most accurate way is to add all the cations and all of your anions, and the anions in a lot of big proteins with side chain dissociation in the blood, they're carrying negative charges around. So usually they need to be added if you have all the numbers. Alright, so what is the anion gap in this case?
20.9.
Did you get that? What are the numbers that we added? What's the chloride? I mean sodium, sorry. What is it? What's 130?
132.
132, okay. So we add that to our potassium and we minus chloride plus bicarb. Okay. So for anion gap, please note your bicarb, I want you to look for the arterial bicarb in this case. Arterial bicarb. Where is that? It comes with the ABG. This is why I was making that comment of ABG blood, where they draw it from. Well, once they draw the peripheral from brachial, for the venous blood over here is brachial. Arterial blood, they may have either a large volume or something attached systemically to do, usually they'll do that to get ABG gas and also even to connect them in case they need to do something like that, use that arterial line. So it's the most accurate for you to look at, and I want you to use that number. There were two numbers, the bicarb that was measured with your chemistry that came from the venous blood, from the brachial artery, but we want the arterial for bicarb in this formula. And there's a difference if you look at them. One was 10, one was not too far away, but it's still a little bit different. Okay, everyone with me on this? Let's move on. So the next thing we need to do, we need to check their pre-admission meds. You know that they're insulin glargine, they're doing lisinopril, they have Combivent, the puffs, Advir, they're doing all of these for their COPD. Aspirin daily because they're also at risk for cardiovascular. They already have cardiovascular events several. They're doing Plavix. Okay, inpatient, we're going to change them and start to do, we're going to try to chase down in terms of the infection, try to figure out what is, they already run cultures, both the blood and sputum. So they already done that, but we need to start antibiotic therapy empirically. And we will start our insulin sliding scale, we will look at electrolytes and we will replace fluid and everything as required. And of course, you know that they're taking Lantus 25, but of course, inpatient, we can immediately come in acute setting, emergency room and such. We're not going to do oral, we're probably going to start insulin IV, and you know your procedure, so you're going to figure out how much insulin do they need, based on that glucose. Did Dr. Davis take you through that?
Tomorrow,
Huh?
we have for tomorrow.
You haven't done insulin dose and such that? You haven't done that in the class?
No. We start tomorrow.
Tomorrow is hands-on.
In the class, like this PT class.
Before you go to hands-on, she would.
That's why hands-on was originally scheduled for Friday.
No, it wasn't originally scheduled for Friday, it was on the 5th. And then she requested that it be moved, and I moved it then. She called me back and said, no, it needs to remain on the 5th.
Yeah.
It wasn't, I moved it back to where it was. Because I was told, no, they don't want it on Friday, they want it tomorrow. Okay, so,
And we're learning it tomorrow, so you see this frustration here. It's okay.
You're supposed to be learning it tomorrow.
okay, so, we're going to come back to how we're going to figure out the insulin, the dosing and such. Alright, so acute complications I already mentioned, so we're talking about DKA in type 1 and some subtypes, type 2. Please folks, follow me, this is very crucial. I'm taking this very, very slowly because you need to get it. If you just get what you're looking for, what needs to happen, that's all you need. You have what you need to manage diabetic patients and understand it. So, the two complications you already mentioned is we are doing ketosis. I'm going to talk about hyperosmolar later. The subtype with type 2s have hyperosmolar, they come in and they have this ketosis. They shouldn't, but they do. It's a subtype that has it. So, all type 1s will never. Type 1s will never have hyperosmolar states. But type 2, there's a subset of them that will have DKA, even though, they're type 2 diabetics. Okay, so there's a subset that can have DKA. So we know the origin of the problem is the absolute or relative contraindication, like we mentioned. So with that comes the volume depletion, with that comes acid-base disorder, and fluid and electrolyte imbalances. Alright, so here I'm just giving you the two types and some presentation. Like I mentioned, type 2 can have DKA, type 1s don't. They only have DKA. Type 2 can have DKA, but they can also have hyperosmolar states. Alright, so I'm going to move fast and show you how do we manage. Let's see if we can increase this. So management, we already know what our problems are. That's what we spent the last few minutes doing. Okay, so we know our problem is there's some insulin. So that for each 4 areas we need to be looking at. Insulin, high glucose that's caused diuresis and electrolyte imbalance, and they're going crazy all over. We have a lot of ketones and acids in the blood, and then we need to run in there and give them insulin. So insulin replacement, because that's what started the whole thing. So management then will include for you to do 4 things. You're going to be trying to replace that insulin. How much do you need, and how fast are you going to replace? You're going to look at the fluid status, dehydration, to what extent, how much volume have they lost that you need to replace. You're going to look at acid-base status. Do we need to titrate them back? Can we wait for the body to correct, which is very slow when it goes down that ramp of biochemical pathway? It takes it about 24 to 48 hours to get there. So to correct it, it takes just as long. So correction doesn't mean that you give them insulin, suddenly everything in the body, the chemistry, biochemistry, and all the mechanisms go back. It's almost as if you're going to have to nudge them over in 24 to 48 hours. So it takes a while. So insulin therapy also will be assessed and managed over that period of time, being patient until when you're about to discharge them, you switch them back to things that they can use at home. Do we need to do BICAR? It depends on where the ABG pH is. If the pH is already somewhere around 7, sometimes even some from whatever, if they already know coding and, they probably will be in ICU, and we probably can also use bicarb drip to titrate the acids. Of course, you can look at serum osmolarity for managing in terms of when you correcting all the different things. You're going to check serum osmolarity, you know where you started, you know where you want to go to, so that becomes one of the things that you monitor. And finally, also, I talked about electrolytes. You're going to monitor all of those. Okay, so mortality is usually less than 5 if you get to them quickly. And usually mortality mostly a problem with the elderly. Of course, everything with elderly is always very severe. It can also happen in type 1 in children. Okay, so 1/3, like I already mentioned, type 2 can have DKA. It used to be like when I went to school decades ago, the thinking and the way they taught us, type 2, 0 DKA. But now, since medical research and have shown that type 2, there's a subset of them that can have DKA. They already talked about the etiology, that's infection, omission are the major things that usually happen, but then there's the other 3 I's that I mentioned that can happen. The counter-regulatory hormones, I already mentioned them, insulin, glucagon, and the way that they're going, the directional flow of their actions, depending on what's going on in the body, is what's on this table. And then I just gave you how that counter-regulatory hormone does in terms of the weights of it counter to the other 4, and if insulin goes up, the other 4 goes down. If insulin goes down, the other 4 will come up in full force and overcome and bring everything that we don't want into the bloodstream. So diagnosis, we talked about it already. It's history physical. You're going to sit down with them and really review everything. Symptoms, you already gone through all of it. In type 1s, weight loss may be part of it. You talk about, they talk to you about metabolic weakness. They always talk to you about running to the bathroom. But the other thing that could happen is that mental status change. The mental status change is coming from too much osmolality in the blood, decrease in perfusion, blood volume in terms of fluid and water, cellular dehydration. And you remember when I asked what goes on with dehydration, you all told me the cells will shrink and collapse and die. That's exactly what's going on in the brain. If it happens in the brain, mental status, when you ask them, alertness question, they will not know who they are. They may not even know where they are. So this is why you have to look at that orientation. They will always talk to you about abdominal pain and of some nature. And then, of course, if you check their skin, the turgor will not be right. If you check the mucous membrane, particularly in the mouth or the eye, it will be gunky because you see that they're dry. They will be tachycardic also, and respiration, cosmal respiration, fast. And if you come near and breathe and breathe the odor, you breathe the specific odor of ketone breath. Okay, lab findings, we already talked about it. In mild setting, this table is just showing you from mild to severe cases of plasma glucose. You can find them between higher than 250 to 1,000. I mean, when I used to do medical ICU rotation, we saw some that would come in and their blood sugar is in thousands, like maybe 1,500. They're always acidotic. Okay, the pH is always running. Remember, I told you 7.32 is acidotic. Serum bicarb, you find it. The more severe everything is, the more severe all of they have consumed. Because you need to think about it like your chemistry class where you were titrating acids and bases. The body does exactly the same thing. It has anions and cations, and those bicarb type or alkaline type products that helps to titrate, bicarb being one of them, but there's some proteins that can also do that titration of acids, which is basically binding the acids and taking them off the blood, and vice versa, that can also happen. Serum osmolarity, if you check them, is variable, but you need to always calculate it. You need to always calculate anion gap. It will always be high. Mental status, you need to always check that. They will be alert if you smile, but they will go to stupor, confusion, and even coma if it's very severe. Of course, a lot of this time, things you will find in inpatient setting, but you need to know so that you can recognize in your clinics. If you find someone coming to your clinic, outpatient setting, and they're at the beginning of this, you need to be able to figure it out and be able to send them, triage them appropriately to maybe 911. They can come to your clinic and then collapse in your pharmacy. Then of course you need to call 911. Okay, so this table is just showing you what kind of values. For the most part, you can count on one thing. The normal values, everything is going to be abnormal. So just count on that and know the normal ranges and know where they will tend to be for acidosis. So we already talked about those four things. Hyperglycemia is a problem, ketosis is the problem, dehydration, and electrolyte disturbance. And you all know, you can explain to me and explain to everyone what is causing it. It started with glucose. Insulin not being there and glucose being too much. So the hyperglycemia had, what do we need to do? Well, they don't have insulin. We need to replace insulin. When we replace insulin, the gluconeogenesis, I told you, it takes about 24 to 48 hours, which is about chemical abnormality. Usually glucose is being taken and it goes through glycolysis. But if you don't have glucose, your body don't wait for you, it just starts to make glucose from other things. That process starts. So to convince it to go back, it takes a little while. So you need to put insulin on board, and with that, you try to reverse gluconeogenesis and force the glucose to be used by peripheral tissues. As soon as you do that, glucagon release will try to be decreased, or so that you can go back to doing glycolysis and stop doing gluconeogenesis and glycogen lysis. Those two you want to stop. As soon as you bring insulin, and then you're going to bring that balance back, and glucagon will come into play again in the normal ranges, and things will happen. And I said it goes for about 24 to 48 hours. Clinical features, glucosuria, with that you get electrolyte imbalance and that dehydration. So we need to always calculate how much water deficit are they in. So when they come in, you need to do total body water deficit calculation. You need to check the electrolyte from your chemistries, and then we're going to replace accordingly. And if they're in deficit of like maybe 7 liters or 10 liters, you don't put all at once. You give maybe 1 liter immediately over maybe 1 hour, and then you have to transfuse the rest, or infuse the rest, not transfuse, infuse the rest over 24 to 48 hours. Because you remember I said, there are 2 reasons why you don't want to just pour everything in. Even if you do that, the correction, the body biochemistry and things that have been altered, it's not going to go anywhere. It's not just immediately going to snap back. But the danger is that if you force all the fluid in immediately, you will cause the reverse of all of the problems. Dilution, and you're going to cause swelling of cells. And swelling of cells in here leads to the same thing that happened when it shrunk. None of that you want. And you don't even want too much fluid crossing the blood-brain barrier and getting edema up here. You don't want none of that, because that also is leading to death. Okay, so because of cerebral edema, we want to do this slow stuff where we give them so much in 24 hours, so much in 48 hours. But we also know some other things can cause dehydration to compound it if they're diuretic, if they were feverish, if they're having nausea, vomiting. That will compound dehydration. And this patient told us all of these, except for the diuretic. We didn't see whether they have that at home. I don't remember on that profile, but it could be there. So if they were vomiting, they have diarrhea or nauseous, they already got dehydrated from that one, in addition to this problem with glucose. All right, so we already talked about it, so we're going to look at sodium low, we're going to replace. How do we calculate it? We can correct our sodium, measure sodium plus, here's the formula right here. There is a formula. To correct the sodium to see how far off are we. So, usually we do this calculation just to see, because in our large volumes, usually we'll start with normal sodium or half normal with what we will be using. Usually you give these people dextrose because they already have so much. So your large volume should not be a dextrose at the beginning until blood glucose comes back, which usually within 24 to 48, it comes back below 250 milliequivalent per liter. At that point, we can switch out large volume to D5.5 or something of that nature, or D5NS. But at the beginning, no. And actually, when people come into hospital, for patients that don't have DKA or anything, but if they're diabetic, you don't want to start, if you need fluid, once they're diabetic, everything that you have to give them has to be made in normal saline. Alright? So that includes your antibodies that you're going to be piggybacking and all of this other stuff. Alright? So I'm going to pause here for you all to just calculate for me what should be the corrected serum sodium in this patient. Quickly. And I have a poll where I'm going to get at some point there's a poll here that you have to take for me, and that will give me the census of who is in here for class participation credit. Okay, so we was on the case for that patient. So we're still walking and looking at that patient. So measure sodium plus 0.016 times glucose minus 100. I'm talking about that one patient. So that's the patient that came that we started to think about all the facets of what you need to do.
The original glucose 425?
Yes, that's their glucose. So you're looking at, to correct, the glucose that you're looking at is the glucose that they have in the blood that we measured.
What is the value for the glucose again?
Please don't ask me. You have the case in front of you. So go back and check.
It's not open.
Yeah, go back and check, because you're not going to sit there and be asking the nurse, what is the glucose when you could look it up yourself?
No, I didn't know we had.
Yeah, you have the case. You have the case.
It was 130.
For this, your glucose comes in your chemistry, so usually it's not part of ADG, so that's fine. What is it? How much?
143.
Okay, good. Alright, so that's what you should get, and so you could figure out 143, so you really don't need to do any corrections, because actually we found out, so you're losing, but since you're going to be using amoxicillin for your volume replacement anyways, you're going to be, it will just be normal still. All right. So we already done that. So determine the sodium deficit. All right. And where did I go on? Where did you all start from? Because this is what I'm getting, 198, 190.
It was
On your case, you had a different sodium than the case.
yeah, we had a
Okay.
difference.
All right. But this is what you need to do then, so that's how you get it. All right. Okay, clinical features of electrolyte disturbance. Was there a question? An answer they wanted to give me? I had something. All right, so remember I said potassium. Okay, so we've looked at what sodium is doing. Now potassium. Potassium is doing something very crazy also because remember, it's waiting outside with glucose. It's not able to get inside the cell until you get insulin on board. So once you start to, this is the normal transport or movement of potassium. Usually under intracellular fluid, extracellular fluid. Potassium is usually in the intracellular fluid inside of cells. Now there's an hydrogen ion potassium ATPase pump, and that pump has something to do with insulin reacting with it and creating this flux or the movement. So usually the things that will shift potassium outside of the cell, hyperosmolarity in terms of like what we have heard with hyperglycemia with the patient, exercise will also shift some outside of cell lysis will shift it outside. The things that tend to drive it inside the cell are your insulin and beta agonists. So this is how come some of your patients that are on beta agonists for what kind of conditions?
Hypertension.
Beta agonists for hypertension?
Myocardial.
I said beta, listen to what agonists.
Oh, and
So now you want to give someone hypertension beta agonists to kill them off. Is that what you're trying to do?
You mean like
No.
asthma?
I said beta agonists. So
Like asthma.
like asthma,
COPD.
COPD, and you remember a patient has that, so you may be on some agonists, and even unrelated, what else can you use beta 2 or beta agonists for? See how things are connected. And this is how they're going to ask a question on the board. You must remember, because you're the pharmacist, you need to know, what can that thing do and how does it contribute to anything here? So beta agonists will shift potassium inside the cell. This is how come some of your patients that are on beta agonists come to you and you do chemistry and the potassium is low. And you say to yourself, why is it low? It's because it's been driven inside the cell by the drug that they're on. So drug-induced conditions, we use them to favor us in some of the disease states. Some of the side effects are some of the things that we want even to happen. Like you're trying to drive potassium inside the cell, you want to put on the patient on some beta agonist because he will do that. He will drive it inside the cell for you. Okay, insulin and beta agonists will drive potassium and shift it inside the cell. And so the movement and your measurements, you need to take all of this into account as you're doing stuff. And of course, implication for potassium when it comes to EKG, cardiac rhythms, should not be lost to you as well. Same with sodium. So phosphate also part of the electrolytes that are disturbed. It may be normal or elevated. Okay, so insulin deficiency, hypertonicity, increased metabolic states that's happening because of lack of insulin. But once you start to put insulin back, like I said, between 24 to 40 hours, the normal biochemical processes comes back. But at the beginning, we need to replace phosphate accordingly. So water and electrolyte deficit, of course, deficits total in general could be, total water could be up to 6 or even more liters that you want to replace. Sodium 7 to 10 per kilogram. Chloride 3 to 5 per kilogram deficit. Some calcium, but of course magnesium also, and phosphate disorder. So goal of therapy, you want to identify and manage what precipitated it. Remember your 5 eyes? A lot of times it's infection, a lot of times they were not compliant. If they're not compliant, you just have to start them back on therapy and then stabilize them and get them on the way. If they have infection, we need to also treat the infection to try to get them out of the picture while we do other things. We need to rehydrate them because they're severely dehydrated. So fluid therapy, we need to correct hyperglycemia. So at this point, it needs to be insulin therapy. And that typically will resolve these acidosis because basically what the acidosis came and ketosis came from alteration in insulin, glucose metabolism. We need to manage electrolyte imbalance by electrolyte replacement. Okay, so I have attached this usually in terms of globally what I just mentioned here is same thing in this handout, in this nomogram or schematic. Okay, fluid therapy, we can use large volume, so we can calculate what kind of volume we need to rehydrate, how much volume, and then we start initially, like I said, we may give them one large volume, we may infuse that over an hour, but then we need to infuse slowly the rest of it over 24 to 48. And then you need to, of course, we don't just rehydrate them, but that also would result in improvement in hyperglycemia. It would also give optimal response to insulin therapy, of course, by taking it all around. Severe hypernatremia would be also corrected by this process only by itself. Okay. You need to do fluid therapy management. You need to calculate what is the water deficit. So can you quickly calculate what is the water deficit? We did calculate the serum deficit. Here I'm asking to calculate water deficit. And here is the formula for the water deficit. So you look and we have this calculation that we already done. We did it when we did fluid electrolyte imbalance lecture. So you can take a look at that lecture to see how do you determine water deficit. And so once you calculate that, it gives you an idea of how much volume that we need to replace even to start with. And you remember we need to replace it slowly. So the crystalloids that we can go to are sodium chloride, either 0.9% or normal saline or half normal, which is 0.45. The preferred rehydration fluid at this point until the blood sugar comes down to below 250 milligrams per deciliter. So isolated solutions is what we need because you don't want the body is already hypertonic, and in this case we're trying to get them back to normal. Okay, so quickly do your calculation and let me know what you got. How do you get how much? Alright, so you could do that on your own because I think my time is going. Quick. Alright, so if you don't have any kind of problems, then initial fluid, like I mentioned, would be 0.9, and we could do 15 to 20 milliequivalent, but we can actually do calculate how much it is that they need from the other formula of total body water. And then we can then, of course, we need to gradually replace, like I said, very, very important. You don't want, the reason why you want it to be a gradual replacement, most consequential problem will be this cerebral edema. The faster you replace, the more problem you're going to get. And you actually can feel them, really. So once you get to a stable point within 24 hours, then you're just going to look at hemodynamic status. You're going to always be looking at the hydration status, serum electrolyte, urinary output. You need, because as you put it in, you want to make sure that they have appropriate urine output so that things will be in balance. Otherwise, if you push them in one or another direction that you don't want. So, insulin therapy, of course, here, and what is the replacement for insulin? What is the dose that you're going to have to start with? Have you done that in your diabetic lecture? You should have done that. How many units per kilogram do you start with? All right, so, okay, so you're going to catch up with that tomorrow, because I think even your hands-on tomorrow is going to be about managing the patient and doing that dosing. So hopefully you get it all squared up tomorrow. This information is all linked, and you use them in patients that have everything, including diabetes that may be presenting with DKA. So you already know how to calculate anion gap. You already know how to figure out what you need to lead to, what everything that you're trying to lead to. You want to see resolution, and resolution will start around the time that glucose level goes to less than 250. So somewhere about 200 milligrams per deciliter. And then, of course, that in addition to, if you look at your serum bicarbonate, it's going back higher, and your venous pH is also going back towards normal. You know that the chemistry that has been altered, biochemical situation that has been altered is going back to normal. Like I said, this often takes up to 48 hours, so it's not something that you're going to push quickly, because the human body and the equilibrium is so finite and, finicky and very, very, so you need to really be careful in the way that you're correcting. You don't run in there to correct in 6 hours. You're going to kill them from several consequences. So you already calculated this, so we can move on. Insulin therapy I already given to you, and tomorrow I think you're going to gain more insight into how you dose insulin. And then when it comes time to send them home, here are the stages of changing that whole IV to infusion to things that you can then dose intermittently, either injectable or whatever method that you want to use. Here are the steps, and I'm going to leave this slide for you. When you go through with Dr. Davis tomorrow, it will make sense. I want you to have this slide next to you, and when she's going through what she's going through in the morning, because I'm telling you that afternoon hands-on, I think it has something to do with figuring out. So here, I wanted for you to build. Once you've done your lecture tomorrow, go back here and build JJ's insulin therapy, step 1, 2, 3, 4 that you will take. I think tomorrow you'll be more competent to do that. So, of course, electrolyte imbalance, you're going to replace them. Potassium, usually for potassium, you want insulin therapy, and you want to make sure that potassium is not less than 3.3. So usually when you infuse insulin, you need to put potassium in the fluid. So when you start your large volume, be it normal saline or half normal saline, because that's actually when you put your insulin or piggyback your insulin on that, then you need to be watching potassium. I need to include potassium actually in those fluid, so that as you're losing potassium, as you're driving into the cell, it is not completely going to zero in the extracellular fluid. Then phosphate you're going to replace if need be. Okay, you're monitoring everything, you're looking, and you may have to replace, because lack of phosphate or decrease can cause cardiac and skeletal muscle weakness, and also the lungs, the muscle. Okay, so basically phosphate lack of, remember phosphate? Big in what? Major energy generating system in the body. What is that system that needs phosphate? That's right, ATP, and everything is functioning. Remember, we're talking about chemical processes that is going on. It's looking for its phosphate. You don't have. Okay, so trouble with that. And at the junctions of action potential generation, particularly in your muscle cells, cardiac cells, I'm just gonna handle that one. Okay, phosphate, so we can replace it when necessary. Of course, you also need to monitor your potassium because they are linked, and calcium. Okay, so treating of DKA, you need to know the conditions that brought it on. You need to treat that, whatever that is. You need to, the problem that's the consequence of lack of insulin include fluid dehydration. So of course, fluid therapy. You need to know that you need to replace insulin because that's one of the things that brought us to where we are. Whether we intentionally didn't take our doses or we just got into trouble due to some other issues like infection and also electrolyte imbalance. If you know your way around these, you already figure out what to do with your patient. Okay, hyperosmolar state is slightly different. I'm going to run through that with this one patient. Usually occurs in elderly type 2 people. They usually show, if you look, the glucose level in hyperosmolar is ridiculously high. Okay, do you see that? 700 is almost like twice the amount. So if you could look, it's probably like 2 times what you find in DKA. The plasma level of glucose is always like in hyperosmolar is like twice what you find in DKA. They will often not have acetone in the blood. Their pH should be looking very well, you know, but they should still, because remember I said type 2, some of them, they come in DKA. This is why they do the ABG cystatin to make sure that this is not that type 2 that we have presenting with hyperosmolar, but it's actually DKA. All right, so hyperosmolar is reversible, but it's also life-threatening, and it's metabolic complication of diabetic type 2, severe hyperglycemia, hyperosmolarity, same things that's happened in DKA, because the same thing is happening here. In this case, even the glucose is to the wazoo. Okay, so severe. So the glucose is even higher. So the diuresis is even higher. So the chemical imbalance is even higher in terms of electrolyte imbalance because you've driven so much of this stuff out. They're extremely dehydrated or volume depleted. So, and then you put elderly on top of it, then what do you get? Disaster. Mortality 5 to 20%. Predictions of mortality, age, degree of dehydration, hemodynamic instability. Because of course, like I said, anytime these elements of physiological processes in our body goes haywire, you can bet that everything will go haywire with everything else in terms of physiological processes and set up hemodynamic instability, and if you do not correct them quickly, death is coming. We need to look at what is precipitating it. It's the same thing like DKA, something started it. Here, often there's a whole huge degree of unconsciousness, or people are in stupor, you know, there's a lot of neuro involvement.
So would you say that DKA is more geared towards type 1, where the hyperosmolar is geared towards type 2, even though they can happen in both?
No. So type 1 patients, you just said that right, the first thing that you said is right. Type 1 patients, if they have diabetic hyperglycemic crisis, is DKA. And you know why. Because in that case, they cannot make any insulin. You remember type 2, they make some insulin. So when they come, they may have some insulin, the receptors may not be, responsive, but they do make some of their own insulin. So that's the difference. But then there's some type 2 that research have shown they are not able to, or they behave as if they're not producing insulin at all. In those type of type 2s that you cannot say by just looking at them and say, oh yeah, that one, you can't say until you do, they will come, you say, oh, type 2. But they're actually in DKA, but they're type 2. So some type 2 can have DKA, but type 1 never have hyperosmolar. Okay. But usually the consequences are the same. They they don't have insulin around, or insulin is not available to help them as much, they will come severely dehydrated, they will come electrolyte problems, they will come with hyperosmolarity in the blood, electrolyte, everything, crazy. And so management is identical. You don't have to be thinking about, okay, what's going on with fluid status? Of course, they're going to be severely dehydrated. So how am I going to manage the fluid replacement? You're going to be thinking about, at that time, even though they're type 2, this insulin is immunotherapy at this point. You cannot be trying to figure out whether you're going to give them some metformin. All right? Or any of your, glutens. You can, no oral here. It's only insulin that will help when they come in hyperosmolar. Only insulin at the beginning. Of course, when you want to discharge them, of course, you can either switch them, or maybe decide people type 2 that probably actually do need insulin as part of their chronic regimen. So this may be, a lot of times, this is where you catch them, the ones that need insulin in their regimen on outpatient basis. Because someone like this, you don't want to give them just oral when they leave. You may want to add some insulin to the therapy. So you do have your options of glargine and the other ones. Okay. Alright, so pathophysiology very similar. Okay, very similar what's going on, because it's saying biochemical processes that are not doing what they're supposed to do. The triggers here, same thing that we talked about, particularly cardiovascular problem, renal failure, infections, a whole lot. Okay, so the diagnosis symptoms that they're going to be talking to you about, similar. They're going to be talking about, oh, I'm fatigued, oh, I went to the bathroom, oh. In this case, they're going to be talking about weight loss, oh, I'm having abdominal pain, oh my God, I'm throwing up. But they may not be able to tell you, because these people, like I said, usually elderly, they're confused already. If they're not stuporous or even gone into some sort of coma, because very high amount of disorder or disease in them. So signs, of course, we already talked about tachycardia. They may be hypertensive, dry mucous membrane. If you look at their skin and inspect it, skin turgor will not be very poor. Diagnosis is basically similar to what we talked about. You want to do the ABGs in type 2s, particularly elderly, still, so that you can rule out the ones that are in DKA that you were not going to be able to say that they are in DKA if you didn't do your ABGs. And here are the numbers for some of the things that will happen in terms of the arterial blood gas comparing DKA to hyperosmolar. Okay, so clinical features then, same thing. Hyperglycemia is there, profound dehydration. You see that I added this word, profound. They're severely dehydrated. Why are they profoundly dehydrated? Because their glucose level is 2 times in DKA. So the guy in DKA comes, glucose is around the 400, 500-ish. These people come 800 to over 1,000. Their blood glucose. So it's always like twice what you find in DKA. They're profoundly dehydrated. They're in hyperosmolar state, electrolyte imbalance, and they often will have some neurodeficits. So when you do that, trying to ask them if they're autoimmune times 3, something will happen. Alright, so similar way that you're going to deal with it. Of course, you're going to be trying to figure out how much deficit do we have here, fluid replacement. You're going to be figuring out insulin therapy, replacement. You're going to figure out where are our electrolyte disturbance and how you're going to replace them. You're going to be figuring out, is there any other thing that's going on underlying? You're going to be trying to deal with that as well. So same equations to calculate dose of therapy, dealing with anything that precipitated this whole thing. Rehydrate them, correct hyperglycemia, manage electrolyte disturbance, and restore them to baseline. Because most of these people have mental involvement or neuro involvement in terms of the fact that they're much more neuro involvement here than in DKA. They may not be exactly in comatose, but they're seriously confused. And okay, so management of fluid, same as DKA. Insulin, again, it depends. Of course, you have to figure out dosing. So I'm going to wait for you all in your classes tomorrow. You gain some of that insight about how to do this. Starting the dose, figuring out how you need to start, and I think some of the hands-on tomorrow is going to be around doing exactly these sort of things. Electrolytes, same as DKA. Insulin, like I mentioned, tomorrow you're going to figure out how you start the dose and the 4 steps that you go through. And then, of course, IVGPO when you want to discharge. Okay, so here's the one. What is the normal osmolarity for our patient? What should it be? Here is a poll. And I didn't put any time on it. So pick whatever you want to pick. Submit. It will give me information as to who is sitting in here and who is not, and who is deserving, because you all spend time doing this calculation, class participation, who is deserving of those 5 points. And I don't care. If you send any email to anyone right now to check into me about, I'm going to be upset. Unless they have there are some people that I know have excuse absence to go do something, but it's not everyone that is not in class. Oh, sorry, did I take it down? I'm sorry. I thought you should know. I mean, this is like just pick one. I mean, what is the normal? What should it be normal? So that you know when you start to treat these people, what are we looking to make sure? I'm not going to say what it is. This is the quiz for this afternoon. In-class quiz and class participation. Is everybody got that?
Yes.
Okay, I'm going to move on because I think our time is coming to an end. Insulin therapy, and I know you're going to get a whole bunch. Insulin therapy tomorrow. Look through this once you've done that, because then you could see now, it will make sense more of these slides after you've done tomorrow. Okay, here is just in terms of you sending them back home, you want to give them insulin plus, some of the meds they're on and some of the newer meds that you want to select, you could select for type 2 in hyperosmolar. Okay, so to recap, for hyperosmolar, we need to rehydrate, same thing, rehydrate this huge deficit. We need to correct the problem with insulin, the hyperosmolarity and hyperglycemia with insulin therapy. We need to check and manage the electrolyte imbalances. In this case, once we do all of that, we will take them back to the neuro will clear, that's also part of the thing that we can monitor for. Oh, okay, like day number 2, they start to know who they are and start to feel better, and they're no longer confused, so you know you're going in the right direction. Of course, in addition to checking your electrolyte, in addition to checking what is your blood glucose, is it responsive, is it less than 200, is it going towards where it's supposed to go? Okay, any questions for me? I'm going to stop right there. Prevention, of course, is the best. Education, patient education, or diabetic management, or self-management before they get there here. Sick day management, because if they don't do the sick day therapy properly, they can also get this problem. So sick day management, you need to instruct them on that, effective communication, and keeping in touch with your patient, and then plugging into your clinic. So prevention is the main thing. Okay, sick day therapy, I'm going to leave that to Dr. Davis for tomorrow. Okay, the volume, all right. Any questions? Any questions? Everything you got, wow, okay, great. So I have,
Confirm the water deficit number? Can I confirm the water deficit?
no, I'm going to calculate first. You didn't calculate, you or didn't?
I got it, so can I confirm?
text me, because I want the other people to do this. So, folks, I have 6 questions on the oh no, I'm not part of it. Yeah, I'm going to be part of the integrated exam next week, right?
Yes.
Okay, so, this actually is going to be 6 questions. Folks, if you didn't know this, basically, you know, when I come to class, I'm not beating about the bush. It's what you need to know to be able to competently do what you need to do, so you can expect everything that I ask you. These 4 things that you need to know, how to manage this stuff, like you've gone over what's causing it, what are the problems that you see, and how to manage it. Those are my questions, folks. So if you're in class, there is no reason why you should fail this stuff. I mean it. Okay? Thank you all. Class dismissed.